A normal aorta is life. A dilated aorta is a countdown. This is your rapid, exam-focused guide to recognizing and managing aortic aneurysms with confidence. Aortic aneurysm is defined as a permanent, localized dilatation of the aorta, where the diameter is more than 1.5 times the normal vessel size. There are two major types you must recognize for the exam: abdominal aortic aneurysm and thoracic aortic aneurysm. An abdominal aortic aneurysm is most commonly located below the renal arteries. It is far more common than thoracic aneurysm and is strongly associated with smoking, advanced age, and male sex. A thoracic aortic aneurysm can affect the ascending aorta, the arch, or the descending thoracic aorta. The ascending aorta is the most frequent site. Hypertension is the key risk factor, and connective tissue disorders such as Marfan syndrome and Ehlers-Danlos syndrome are classic associations. Now think of the major risk factors. Smoking is the strongest risk factor for abdominal aortic aneurysm. Hypertension is the strongest risk factor for thoracic aortic aneurysm. Other important risks include age above 65 years, male gender, family history, and genetic aortic disease. Most aortic aneurysms are asymptomatic and discovered incidentally. When symptoms occur, they depend on the location. In abdominal aortic aneurysm, you may see abdominal pain, back pain, or a pulsatile abdominal mass. In thoracic aortic aneurysm, think of chest pain, thoracic back pain, or compression symptoms such as hoarseness or dysphagia due to pressure on surrounding structures. The most feared complication is rupture. This presents with sudden, severe pain, profound hypotension, and shock, and it carries a very high mortality, especially in ruptured abdominal aortic aneurysm. Dissection is another key complication and presents with tearing chest pain radiating to the back. This is more commonly linked to thoracic disease. For diagnosis, ultrasound is the first-line investigation for screening and surveillance of abdominal aortic aneurysm. It is quick, non-invasive, and accurate. CT angiography is the gold standard anatomical test for both abdominal and thoracic aneurysms and is essential for preoperative planning. MRI is useful when detailed thoracic anatomy is required or when contrast CT is contraindicated. Chest X-ray in thoracic aneurysm may show a widened mediastinum. Management starts with medical therapy for small aneurysms. Strict blood pressure control is essential. Beta blockers are commonly used, and ACE inhibitors may be added. Smoking cessation is the most important lifestyle intervention. Regular imaging surveillance is required to monitor aneurysm size. Intervention is indicated when the risk of rupture becomes significant. For abdominal aortic aneurysm, repair is recommended when the diameter reaches 5.5 centimeters, when there is rapid expansion, defined as more than 0.5 centimeters per year, or when the aneurysm becomes symptomatic. For thoracic aneurysm, the threshold is usually 5.5 to 6 centimeters, depending on the segment involved. There are two repair options. Open surgical repair is used for large, symptomatic, or anatomically complex aneurysms. Endovascular aneurysm repair, or EVAR, is a less invasive option and is commonly used for abdominal aortic aneurysm when the anatomy is suitable. Screening is a very important MRCP point. One-time ultrasound screening is recommended for men aged 65 to 75 years who have ever smoked. Screen first-degree relatives if there is a strong family history. Now summarize the key differences that examiners love. Abdominal aortic aneurysm, below the renal arteries. Smoking is the dominant risk factor. Most common site is the infrarenal aorta. Presents with a pulsatile abdominal mass. Ultrasound is the best initial test. Repair at 5.5 centimeters. Thoracic aortic aneurysm. Most commonly affects the ascending aorta. Hypertension and connective tissue disease are major causes. May produce chest pressure or compressive symptoms. Chest X-ray may show a widened mediastinum. CT angiography is the key imaging test. Repair threshold around 5.5 to 6 centimeters. Prognosis depends entirely on size and rupture risk. Small aneurysms have a good prognosis with surveillance and risk factor control. Ruptured aneurysms are surgical emergencies with very high mortality. So for the exam, always think of three things: location, diameter, expansion rate. These three determine the diagnosis, the surveillance interval, and the timing of intervention.